Exactly, sir. Because the access issues and the network issues are so much widespread. I know many people who are right now having networking issues and everything. So I believe that it's good to keep
Yeah.
the recording. So,
Yeah.
sir, you have a lot of things to like. When I was making your biography, a little introduction, so mashallah, you have a lot of achievements. So I've been thinking what to say about you because there were so many things, very notable
Well,
things.
so simply, I'm a professor, pediatric orthopedic surgeon, a professor in Palestine Polytechnic University, and an adjunct professor in the University of Toledo in the U.S. And 80% of my work is scoliosis, and I'm a global surgeon.
Yes.
Beside being a professor in pediatric orthopedic, and one of my main interests is how to teach the surgeons in low middle income countries how to implement this service in their countries, and also to understand the growing spine by itself and how can we deal with that in the most easy way that is non-complicated, non-expensive, reliable, affordable, and can be done all over the world, whatever the health context is. So well, you can just say that. So I'm a professor in pediatric orthopedic, global surgeon, trying to teach, to implement this service through giving the local surgeons, and also try to understand more how that growing spine works so as we can understand better and do something more reliable with least complications.
So it's very humble of you because I know you have much more than this to share. These are the cardinal things. Obviously, we really appreciate it, but obviously, you have a lot more of leadership roles everywhere in AO Spine, in Banner
Yeah,
Spine
but
Society.
we'll not spend the time showing what are the titles that I had. It's much better for the audience to know what I'm doing.
No, obviously, but sir, you have a lot of things. You are an inspiration for all of us. So thank you very much, sir. It's an honor. I was so pleased. I was so excited to actually welcome you. So it's. I cannot believe that you are here. I'm so happy. So thank you so much for joining us today.
Thank you.
Would, would
Thank you
you
for
like?
having me.
No, sir. Honor is all mine. Uh, I wish everyone to keep your mics muted. I think I have also done. I've also turned my settings. So I wish if there is still anything that's left, please keep your mics muted so that we can enjoy the lecture. Sir, would you like you? I know that it's 11 minutes earlier, but since you are here, I just don't want to keep you waiting for long. Would you like
No, no,
to start the webinar?
whatever you want, but I think there are people who would come at the time. So maybe they'll miss something. So I would prefer to wait for until the time that was scheduled already is there, and then we can go, and I'll talk for 30 minutes.
Thank you very much, sir. This is huge, sir. So I also wish if any participant has any comments or questions, they can, he or she can just write the comment and the query in the chat box.
Yeah,
Sir, I believe, sir, we will take the question at the end of the session so that we can have a totally
yeah,
uninterrupted lecture.
yeah, you're right.
Sir, I think that, like you have very nicely mentioned, many of the techniques that we now discuss have a lot of issues regarding their application in the low middle income countries. I'm also from low middle income country. In Pakistan, we do not have a lot of resources as well. So I think it is very important to bring it to light that there are constraints and we cannot apply everything.
Yeah, well, this is one of the advantages of the APC actually. And because of that, it has spread it massively. Since it was done and people were comfortable with it, whether in low middle income countries, even in the rich countries, because it's safe, having small learning curve, and can be implemented whatever the health context you are having. So, and because of that, for example, in Lahore, it's done massively, this technique. In Rawalpindi, in the military hospital, It's done. This is in Pakistan, I mean, your country. Not talking about India, Vietnam, Nigeria, Turkey, Jordan, I mean, Egypt, everywhere. And the good thing about it is that none, not a single surgeon whom I know that have done the APC technique and stopped doing it. They are doing it more and more. So this means that this technique is something that, any surgeon want to do something that is more safe and more reliable and give better results. And I think the APC have done that. And these are actually the two main issues about the APC. I'm looking now at the APC as a part of a vision. It's not just a technique. Because, there are two things that you can recognize about it. That it is it is a new technique that instead of going iatrogenically, correcting the spine, adding length, which might work, might not work, like the distraction techniques or like the compression techniques. This technique doesn't iatrogenically do anything. It just try to get the pathology to be a physiology by doing something to control the growth in a way, but not stopping the growth, not doing distractions or anything to add to the length, but to control the apex, that it can modulate with time to be more physiology, not to not so it's not like trying to iatrogenically correct the pathology by uh, by forcing it in a way or another. So it's a posterior tethering that control the apex, which is a new thing, though in spine surgeon, in the growing spine, more and more is shifting to the tethering, but still up till now, the most popular thing is the anterior tethering, which has a lot of issues also. Uh, and uh, and the other thing is that it can be done within any system. You are not stuck to specific implant. You are not stuck to, and also it has a short learning curve. So the standard spine surgeon can do it comfortably. And this is the other thing is that I'm always giving the example of the car. The car, when it was invented, it was very expensive and was only for the people who are very rich. When Henry Ford did the production system, all what he had done is that get the car to be affordable to the middle class, and because of that, the car industry flourished. So we want still until now the early onset scoliosis is done by elite small number of people that can do. With this technique, you can disseminate the experience and you can disseminate the skills for that. So these are the two main issues actually. If
Exactly,
you
sir.
want
You
to
have
talk about the title of the APC.
Yes, sir. So it's like basically like you have very rightly mentioned, you are actually trying to address something like turning into physiology. It is basically this is huge, and especially
Yeah,
it's very important.
this is the medicine. You are trying to shift the pathology to physiology, but not to keep the pathology and trying theologically to force it in a
Yes.
way or another. I think this is a better way. That's all.
This is basically very intelligent, sir, but it takes a lot of wits to find this way, because most of the time whenever we are doing something, we are actually cognizant of the fact that we are adding something actually new. Iatrogenically, there is something that we're like, okay, we are proceeding it, but many surgeries like require implants, something like this, which have their own issues and everything. And so there's
Yeah,
another thing which is very, very important is that is early scoliosis is the age group of growing spine, which is extremely important to take into account. You cannot do everything, and the number of surgeries sometimes,
yeah,
we are not going to expose the
And
patient.
also, by the way, also avoiding the follow-up, which is a crisis. For example, in Pakistan, it's very easy to lose the patient, very easy, because you don't have in every hospital good filing system, and also people are from far away, and they think 1 million times if they want to come back because of the expenses. So it's not easy for them to be followed up. So this avoids the 6 months follow-up to do the distraction, which is very, very important in these countries. Unlike small countries that the patient can come and so these are many things that are on the ground, and we should acknowledge when we deal with these people.
Exactly. So this is very, very important. Like all these points, I think these are the basic cardinal issues that we face each day in our practice. Because, like you have very rightly said, sometimes we have to keep the records of patients. They don't even come back, and they do not tell us what's really
Yeah,
going on. Even if they give you a phone number and you just call them up, they you may not be able to
it
reach
will
them.
be canceled. Yeah, nobody will, even if they respond, they'll say, okay, okay, okay. And then they'll not come.
Yes. They don't have anything unless there is something very serious going on. Like I deal,
Exactly.
yeah.
Yeah, but because of that, we have this quote in Palestine. I don't know how it is in your country, but no news means good news. Because
Yes,
if they don't come, that means there is no crisis. Yeah,
exactly. This is the same thing. We also say this that no news is good
yeah,
news. So it's like that. So if they don't come back, it's okay. They must be doing fine because they don't want to see you again. So it's an
yeah,
issue. It's a huge thing. Thank you very much, sir, again, because I think it's very important to tell everyone about this important technique, and especially my neurosurgical colleagues are were quite excited, and they really wish to know more about it, to learn more about it. So it's a huge thing,
yeah.
sir. I think we
Actually, more and more neurosurgeons are going to scoliosis and pediatric spine deformity, unlike 20 years ago that it was stuck for orthopedic surgeons. Yeah. So I'm happy
exactly.
that they are interested.
Exactly, sir. So spine surgery is getting a lot of attention right now in Pakistan as well, and we do not have any specialization systems. Sir, even I had to travel to New York to do a specialization in neurosurgical oncology myself. We do not have any type of further training here in Pakistan, which is a little awkward. So many people, if they will have to opt as a specialization, they do not have any sort of a training here locally in Pakistan. So they usually have to go abroad or just try to find a good mentor who can actually teach them techniques, and they can just learn it and do something. But again, the learning curve thing is another point, and a good mentor is also hard to find who is dedicated to teach. So which is I think which makes the whole lot of difference.
Yeah, you're right.
So we've got just 1 minute to start. Would you like me to
Yeah,
start
you
the
can
introduction?
begin. Yeah,
Thank
yeah, of
you.
course.
Thank you so much. So again, welcome everyone. It's an honor and pleasure to welcome you all, and I'm so happy to have the honor of inviting Professor Alaeeldin Ahmad, who is a neurosurgeon, who is a pediatric orthopedic surgeon from Palestine, and who is the pioneer of active apex correction technique that we all know about. June is considered the month of scoliosis awareness. So it's a huge honor to invite Professor Alaeeldin today. Professor Alaeeldin Ahmad is a distinguished pediatric orthopedic and spine surgeon based in Ramallah in Palestine. And with over 26 years of clinical and academic experience, he serves as professor at Palestine Polytechnic University and holds adjunct professorship at the University of Toledo in USA, in the United States of America. He's a global leader and an advocate of global education. So, like Professor has just already mentioned about his interest in spreading global education and training, he's a global leader in pediatric spine deformity care, and he has pioneered the techniques such as the active apex correction, for which we have the privilege of having him today. And he has played a prominent role in several major orthopedic societies, including the SICOT, the SRS, NAS, AO Spine, POSNA, EPOS, and also has served as the vice president of the Pan Arab Spine Society. Um, he's vice president till 2027, and he has authored a book on early onset scoliosis management in resource limiting settings and more than 27 patients and 9 book chapters. Actively engaged in global surgical education, delivering international lectures all around the world, and leads in training initiative across Asia, Africa, Latin America to empower local surgeons. So he's a visionary surgeon, an educator, an innovator, more focused on providing the best possible treatment in low middle income countries so that you do not have any sort of issues like we're gonna do it. It's very huge, but he has told you very in detail. So it's a huge thing for us, especially because I'm from Pakistan originally. I always think about the factor of application in my settings in Pakistan. So again, his outreach efforts are really impeccable, and they are transforming pediatric spine foot care everywhere around the world. So it's a huge honor to have you here today with us. Thank you very much for sparing your time, and we are really honored to have you talk and share your experience, your expertise on active apex correction, as you have given a good title. Active apex correction, a reliable option for treating children with early onset scoliosis. Sir, thanks for joining us. The floor is all yours. Take as much time as you like.
Thank you very much. Thank you very much, Dr. Noor. And I'm really honored to be part of the activities that you are guiding. And I'm very happy to work with you and to see all my colleagues and also participating in this activity. So I'll talk now about APC mainly. And APC, active apex correction technique, is a technique which is done for children that are having spinal deformity according to the SRS definition, that what we call early onset scoliosis, which is a term, which is not a disease, means that you deal with spine deformity in any child, whatever the etiology is, below 10 years of age. And I'll share with you my presentation so as it can be very clear. So as Dr. Noor have said, I'm a pediatric orthopedic surgeon, and one of my interests is early onset scoliosis, and also I'm a global surgeon, and I go to many countries all over the world. And this is my email and my WhatsApp number in case somebody wants to connect and ask more questions or want to know more details, or is more interested to know more about the technique. So we'll go to the second slide. So as I said, early onset scoliosis is a term, it's not a disease, and it's not specific to an etiology. So what we learned in the last 2 decades, that early onset scoliosis is not only a spine problem, but affects the lung and the thorax. And this is a major issue we need to acknowledge, because if you do a fusion of the spine, it's not fusing the spine, it's fusing the whole trunk, which will restrict the normal growth of the lung, since we know that the growth of the lung is mainly until the age of 8 is by the multiplication of the alveoli. So any restriction of the multiplication of the alveoli will affect the child during his or her growth. So early onset scoliosis need to be managed in a non-fusion technique. Avoid fusion with evolution with the non-fusion options. And up till now, there is no consensus about any of the approved surgical techniques in management of early onset scoliosis. So what's the ideal management of early onset scoliosis? The ideal management is to maintain a corrected when you want to do the surgery. I'm not here talking about the general management, because I'm a big fan of delaying the surgery as much as possible by using casting under GA or bracing. And this is hugely important in management of early onset scoliosis. And when I go to any country and we try to implement early onset scoliosis services, one of the major issues that I try to show my colleagues and to share the knowledge about how to do the casting under GA according to Mehna, exactly according to the protocol, because it makes a huge difference. But here, because of time, we are restricted to the surgical management. So what do you want? You want, when you do the surgery, to maintain a corrected mobile growing spine with normal trunk as much as possible and lungs as much as possible with minimal complications. Since we all know that early on, why 90% of the people who are doing scoliosis don't do early onset scoliosis, because of the complications that come frequently in this issue. So this is what we dream of. And as we can see here, all the techniques like the traditional growing rod, the MCGR, convex hemiphysedesis, or guided growth procedure like Sheila, everyone has an advantage and disadvantage. And until now, we don't have a technique that can be implemented with minimal complications and have a consistent sound. And from here, the APC came as an idea. The APC, if I want to put some titles of it acknowledge the importance of controlling the apex of the deformity. And this was the new idea, the genuine idea that McCarthy came with the Sheila technique. And you can realize in your practice, if you want to practice, and somebody who is practicing the early onset scoliosis, the problem is not the 40 degrees flexible curve that you can put anchors above and below and you distract, then it will straighten up. The problem is with the curves that are 70, 80, 90, or stiff curves, which are the most frequent curves that we see. If you put anchors above and below and you try to distract it, because both of the rods are on the concave side, because the deformity is huge. So the distance between the rods and the apex of the curve is big, and you need much more force to act on it, which doesn't work. And the force will mainly act on the proximal and the distal ones, anchors, if you want to distract. And because of that, I think McCarthy was right when he said to me once on personal, talk, that all what you do in these big curves is you do distraction forcefully, which will cause tear of the capsules of the proximal and distal part of the facet joints, and then it will fibrose. And you do again, you do distraction, and it will be affecting more the proximal and the distal ones because the distance from the apex is huge that cannot work with. And biomechanically speaking, if you have the two rods on the concave side, it means that it has very limited effect on the main curve. So again, when you distract again, it will tear again the capsule, and with the fourth time or the third time, and they thought that it causes a fusion with time. No, it doesn't. And one of the things that is very important to know, and we know it by time and by experience and with the literature. In the literature, they are saying that whatever you would do, 80% of the early onset school, the graduate, need fusion. If you remove just the implants without doing anything, they are not fused well. Even if you have a bony layer, which might be very thin and might not preserve what you have done. So if there is no fusion, so how did it stop? Because the fibrosis is so tight that it cannot work anymore. So because of that, we are, oh, where is the sharing? I'm sorry, oh, okay. So because of that, APC is want to control the apex because this is the major issue. But in Sheila, they control the apex through fusion posteriorly. So if you fuse posterior and still there is growth anteriorly, you'll have the crankshaft and adding on. And this is the major issue of dealing with of growing spine, that if you don't do the anterior and posterior fusion, you'll have a crankshaft. So I thought that why don't we control the apex through non-fusion technique that will cause reverse modulation by imposing compression on the convex side and distraction on the concave side. This is in the, the first surgery that will accelerate the growth on the concave side and decelerate the growth on the convex side according to Hooter-Volkmann's law. So you still preserve the growth posteriorly, but in a way that will modulate the vertebra, and still there is a growth anteriorly, so you will decrease the incidence of crankshafting. And this is the Hooter-Volkmann's law, that growth increase by distraction and decrease by compression. And this is a slide that I can show the difference between the Sheila, which is on your left side with the screws, the screws on, the apex, controlling the apex, the red colored ones that you fuse. But on the right side, the APC, instead of fusing the three levels of the apex, you just see the most wedged vertebra and don't touch it and go with one screw above, one screw below on the convex side. And you do medial translation, derotation, and compression so as to control the 3D problem. And this is the vision also about the APC, is that you don't iatrogenically try to correct the spine by, the distraction things. You try to put a template that you can just get the spine to work by itself with time by implementing or enforcing the Hooter-Volkmann's law. So like in the basic of the medicine, where it's the best thing to do as a doctor is to change the pathology to physiology, and not to change the pathology to enforce the pathology to be much better. And this is the thing that I think the APC have done. It doesn't enforce correction. It just put the apex in a way that can be modulated with time according to Hooter-Volkmann's law and do the physiology. And this is a picture of the APC. So you can see on the left side, the upper part are for example, the proximal anchors. And you can see on the left side, these two rods, which are very clear here. It's the concave side. So you can see we didn't touch the spine except in the proximal and the distal anchors, which are below. And the gliding of the rod, you can see the domino that was not locked in apart here, and it goes gliding. And one of the most important issues about the APC is that, especially in countries, low middle income countries, the follow-up is a crisis. The people are coming from far away, they hesitate to come back, and you lose the patient. And you cannot follow up appropriately every 6 months like we do in the traditional growing growth. Here, the sliding is potentially for 4 years. And if the patient doesn't have a problem or she doesn't have a problem, the family are fine. If they come, that's much better, of course. But if they don't come, still the patient's spine is growing in a way that is safe. On your right side, you can see the tethering screws. And this is one of the major problems I face when somebody would try to begin doing the APC. They just put two screws adjacent to each other. No, you can see the proximal screw, tethering screw on your right side, and the distal tethering screw, and you can see a space between them. This space is supposed to be the most wedged vertebra. And you can see I didn't go in the midline. I did a Wilsey technique. So you go 2 centimeters lateral, you open the trapezius, and then you go with your finger just medial to the longissimus muscle and put the screw in the facet proximally and distally. So what is why I'm always uh, concentrating on three levels? First of all, in the literature now, they realize that the most rotated, the most translated is not necessarily the most wedged vertebra. And it might be the one above or the one below. So you must take three vertebrae to control the apex. And the other thing, if you control the apex and you do the compression, when you have two levels, and I'll show you the next slide. So here you go with the X-ray. You can see the red colored circles are for the tethering screws. And the blue colored one is the most wedged vertebra, which you don't touch. So you have a disc below the tethered proximal tether screw, and you have a disc above the lower tether screw. So you have two discs here. Even so, when you do the compression and you have two discs in between, you decrease the incidence of the degeneration of the disc. And this is very important in the long run of the APC, that you want to have as much as possible healthy discs, because you are trying to work with modulation. So when you put two adjacent screws to each other, it will enforce more the possibility of fusion, and it will enforce more the danger of degeneration of the disc that we all know with the previous compression technique that bets have done. And just putting in between, you have a disc that is compressed above and below, and it will cause degeneration. Here is the thing that I want to talk to you about. This is a curve. As you can see, it is about 81 degrees, severe curve in an early onset scoliosis child. And you can see the apex and the disc, which is opened on the convex side and narrowed on the concave side. You can see the main disc, for example, 18 degrees, 16, 17 degrees, about 13 degrees. So what you need is to get these vertebrae as parallel as possible so as to modulate for the future. And I'll show you what happened. Here you can see on the left side, these discs that I've shown, you can see in between the tethered screws, the opening of the concave side is very clear in comparison to the previous one. There was no opening on the concave side. It was diminished, of course, because of the scoliosis. And you can see here, and also on the convex side, it is compressed more. It's not opened like before. And you can see the difference very clear here. This is a case of APC. As you can see, the proximal anchors and the screws in between the tethered screw. And actually, I did put, as you can see, sometimes if you feel that the curve is so long, like in neuromuscular cases or severe, you can add another one, another screw. You can see the third one, 3 screws. And you can see that the apices in the discs are much better than before. And here I'll show you an example of exactly how you would do the first. We would do the convex side, by the way. Why we would do the convex side first? Because if this is the scoliosis, I'm sorry. If this is the scoliosis, and you have this is the convex side. So if you begin with the convex side and you try according to what I say, medial translation, derotation, and compression, you are trying to push the apex to be more medial, more near the midline, which will improve also the correction that you do in distraction afterwards because it's nearer. The force that you need to correct the curve is much less because the curve became more medial, more going to the medial side. So I'll show you in this video. Hope you hear the voice.
Sir, actually, we cannot hear the voice
Oh,
because
you
you look
cannot hear it. Okay, so I'll
exactly.
I'll, I'll talk to you. Okay.
Uh, yes.
So I'll talk. I thought because it has a voice, but seems to be it's not working here. So what we do here are, the compressor is having the two screws, the two tethering screws, and when you go, and these are the ones that you do the derotation. The medial translation usually comes when you connect the tethered screws of the rod with the proximal or the distal one. So you see here derotation and compression on the same time. You do medial translation, derotation, compression, and you are already connecting it to the domino. Always the tethered rod should be locked, always. And it should be 5.5 titanium, not 4 point. So you see, we did. And then we preserve what we have done by locking the rod with the domino. So you see here, the rod, the tethered rod, you connect the proximal anchors with the tethered screws. You compress, derotate, and translate in the same time. So you get the rod to be more medial, more going to the midline. And how would you preserve that? Because in advance, you are connecting the proximal and distal rods with a domino. The tethered rod should be always the locked one, and the sliding one should be the other one. So you lock it. So here you preserve what you have done. On this film, on the left side, this is the concave side. So as you can see here, you can see that there is a rod holder that because we want to distract, and this tool is controlling actually my finger is on the domino, but the buttress, which is controlled by this tool, is the one that you lock afterwards. So you do distraction, and the gliding rod will be the one which is going up, I mean, and you preserve what you have done by locking the buttress. So when you do distraction and you remove the distraction without a buttress, the rod will come back again. So you avoid that with this thing. So I'll show you. These are the proximal anchors. We connect the rod of the proximal with a rod of the distal. First, we have done the convex side. So you have, so the gliding will be downwards, as you can see. So you do the distraction. Usually in the thoracic spine, it's about 7 to 10 millimeters. In the lumbar spine, it's 15 millimeters. And the one which is, you see my finger is on the rod. And then you lock the buttress. And the buttress might be a head of a screw or a hook or a crosslink, a part of a crosslink that will prevent the rod from gliding back. So, and this is one of the advantages of the APC. So if you have a double curve and you want to do it with the Sheila, so you must fuse the thoracic and you must fuse the thoracolumbar. In the APC, you don't need to do that. You just do the same technique in the thoracic and the same technique in the lumbar. And you can see the huge difference also. You can see the huge difference. And even one of the important advantages of the APC is that you use the regular rods, which you can adjust. You can adjust according to the sagittal contour that is in your mind. Unlike, for example, if you do the MCGR or the Vector or something, all of them, they always say that it's contraindicated in kyphosis more than 40 degrees. Here you can even adjust the kyphosis, as you can see in the thoracolumbar area. And also, like in Netherlands, what they have done in Utrecht University, they joined because they have something called spring technique. And its spring technique is mainly a distraction technique. So they joined the spring, which they have, with the APC on the other side. So you can have it as a hybrid with another technique. And this is the paper. Actually, I've published 7 papers, and the 8th is on the way to be published about the APC technique. All of them are in Global Journal. And this one won the best paper in 2024. It was, now I don't do except multi-center studies to add more credibility to the technique. And this one, the best paper in the Global Spine Journal in 2024. And also, there is a question that comes always confronting me in any Congress, whether you are talking about a non-fusion on the convex side, but it's a fusion. So I decided to do a study, and this study was done in 6 centers, not just 6 centers, 6 centers in 6 countries. And for the transparency, I relied on the report of the radiologist in each center. So I didn't tell them to give me the x-rays and the CT scans, and I'll decide what is fused. And we studied the apex. We studied the 3 levels and the facet joints in between on the concave and the convex side. And if there is, and we relied on a well-known paper in Japan about how you identify the fusion. But in general, when we talk about the fusion in children, it is 2 types. Either the fusion of the facets, it's not an interbody fusion like degenerative, either fusion of the facets, or you have a posterior layer, a posterior bony layer that will cause some sort of fusion. So we looked at each facet and we looked at the distance, and even we measured the distance. If there is a distance in between the facets, it's not fused. And we had 17 patients, all of them with 3D CT scans with at least 1 year follow-up, because we relied on the Japanese paper that said if after 1 year there's no fusion, so most probably it's not a fusion. And with a mean follow-up of 26 months, and we realized that 84% of the facets were not fused. So this is a clear evidence about the non-fusion. Well, somebody would ask me, well, it's 26 months. What about after 5 years? Which is a true and logic question. First of all, this technique is relatively new. So we don't have, a real midterm or long-term follow-up, which is something that, of course, all of us can know. But the other thing, so what if it is fused, it has fused after 10 years? We are not talking about definite non-fusion. We are talking about a child that we are trying to do something that is simple, reliable, and can be safe to expand the lung and expand the spine in a way until they grow up, until they become senders 5 or 6 or reserve 3 or 4, and they avoid the acceleration of the deformity because they are going through the spurt of the growth. So this is what is the point, is that we try to get the spine growing and the lung growing until they become 12 or 13. So this was a paper, and also it was published in the Global Spine Journal about the non-fusion. What about the other thing, about the modulation? I was lucky enough that one of the centers had the EOS imaging, and we studied. Actually, it was not my center, by the way. They studied 11 cases that had 2 years follow-up with EOS imaging, preoperatively APC, and after 2 years. And look what we discovered. Here you can see that the cup angle in the pre and in the last follow-up have a statistical difference. The AVT, apical vertebral translation, there is a statistical difference between the preoperative and the last follow-up. And also the spine length, there is a statistical difference. So it proved that it improved the spine with clear statistical difference. But the other thing is that we took A1, we studied the apex also. We took A1 as the proximal apical vertebra. A2 is the middle, which is the most wedge that we avoid putting a screw in. And A3 is the distal vertebra of the apex. And you can realize here, actually, it was not intentionally, by the way. It was the main intention is to see the ratio between the concave and the convex heights in these three apical vertebrae and compare them with the untethered vertebra outside the tethering area as a control one. But we realize that the convex side here, you can see a statistical in A1, A2, A3, and also in untethered vertebra, there is a clear growth on the convex side, which is statistically different between preoperatively and in the last follow-up. But what about, so in the convex side, there is growth. This is very important. I mean, it's not a fusion, it's by the way. But the main issue of the study is the concave-convex ratio. For example, if you have wedged vertebra, like what I've shown you in the X-ray, preoperative X-ray, and the concave side, the height of the concave side, for example, is 50% of the convex side. And it became 70%. That means that the concave side is growing much more than the convex side, and it will improve the wedging, and it will cause more quadriangular vertebra. And you can realize in A1, the convex concave ratio is statistically different between the pre and the last follow-up. In A2, the same thing. In A3, which is the most distal vertebra, it was not statistically different, but there was a difference. There was a difference, but it was not statistically different. And you can compare it with the untethered vertebra, the convex concave ratio. There was no difference actually between the pre and the last follow-up. And this clearly will give us an evidence that there is a true modulation. And because of that, we can realize that in the Sheila, according to McCarthy, who invented the Sheila, the crankshafting and the adding on was 62% in his cases with 5 years follow-up. Until now, we have 20% of crankshafting, not more. So why would you use APC in your practice? It's a new idea. By the way, if you have a new idea, but with a new instrument or a new tool, you need to go to a hell of a paperwork to approve it by the Ministry of Health, by the university, by the all institutions in your country to approve using this tool. The APC is a new idea, but you can do it with the same tools. So you don't need to go with the process of paperwork and have the approvals. And this is a huge advantage. And it's a posterior tethering procedure, which most surgeons are used to. I mean, the standard surgeon know how to go posteriorly, much easier than anteriorly, which needs I mean, lot of learning curve. Unlike, of course, the people who did the spine in the 80s, I mean, the people who began doing the scoliosis in the beginning of this century, nearly, I mean, nobody is doing anterior approach. So it's much better to go through posterior. And the patient doesn't, the surgeon, we are seeking safe also procedure that can be done by a standard surgeon. Imagine doing when you do the Sheila and you put screws on the concave side and you do osteotomy for a 4 years old child. I mean, anyone who went through this practice is really dangerous. So all what you need is just in the apex to put two screws, one above, one below the most wedge vertebra on the convex side, which is much easier to do and safer. And using two screws instead of six in controlling the apex. And can be used with two structural curves. So because if you do it with the Sheila, you should fuse the proximal and you should fuse the distal. So 3 levels proximal, 3 levels distal, 2 levels upper anchors, 2 levels lower anchors. So what kind of non-fusion is that? And it goes with the geometry of the spine because we are insisting that the tethered rod should be on the spine because it must control the apex, whatever the apex is. So you go with the geometry. So your force can control the apex, the spine, or the deformity much better. Also, it goes with the kyphosis. And this is one of the few techniques that goes with the kyphosis again. So if you have kyphoscoliosis, you can go with it. And can be performed with less invasive techniques. For example, you can do it with a small incision superior, small incision in the middle, small incision inferior. But please don't go for your main task is doing it appropriately. So sometimes, especially we are dealing with children, sometimes take 10 kgs body weight, which is very common in our practice. So you might go with the proximal incision and you have just a couple of millimeters in between the proximal and the middle, and you have very hard time to get the domino in. Just go with the straight and expose the whole area because you are doing extra periosteal dissection and Wilson technique in the apex, whether you open it fully or you don't. And it uses affordable implants. And this is one of the huge issues of the philosophy of the APC. If you invent something and cannot be implemented, it's not an invention. If you do something that can be done and can be done by the standard, not the genius, highly skilled, brilliant spine surgeon. No, it should be done by regular standard spine surgeon safely and can be done within the tools that you have. For example, you don't need to be stuck in a company. All what you need is regular rods, regular screws, regular dominoes, and that's it. So, for example, if you are in Pakistan like Noor, you can use Pakistani screws and system. In India, you can use Indian. In Brazil, you can use Brazilian. In Egypt, you can use Egyptian. I mean, you can use the most expensive also implants, whatever you want, but you are not restricted. And this gives the chance to the regular surgeon to do it. And it has also a short learning curve. And this is one of the most important things I am proud of the APC with. Because one of my colleagues, and he's a friend of mine, a dear friend, he told me, Ala, this technique might not be interesting because it's simple. Well, if you can do something with simple technique and can give good result, it's much better than doing complicated issues. And even it will spread the service much better. I can tell you just a small example. If when we were using the car with regular gear, 1, 2, 3, 4, it was much harder. Then when it came to the automatic, it became much safer, and people were, accustomed more and more to the automatic. All what we need is to have a safe, simple technique that can be affordable and reliable. And I think the APC has this issue of vision. And the surgeon always has a plan B. For example, if it doesn't work and you didn't correct and you didn't control and you realize that the AVT, apical vertebral translate, is still going bad and you didn't control, you can go back again and you try to medialize it again and you try to do the correction procedure again with the same tools that you have. You don't need to remove all of the things and put other things, and it might work. And also, still, you have the fusion as a last process afterwards when the patient is graduate. And also, the control of the apex through non-fusion will decrease the incidence of crankshafting since it's very common in the Sheila. And using the non-fusion technique in adjunct with growth guidance and growth gliding. Also, we are thinking about having a maneuver that will not will avoid the 6 months distraction thing. So you have the growth guidance through the proximal distal and the rods, and you are controlling the curve. So in a way, without a fusion, but the curve will adjust itself. And this is the way that can be done without having a regular follow-up. Also, in the beginning of the APC, I was focusing that because it's an affordable procedure that can be done with all the implants on low middle income countries. But it is also worth it since it gave good results with simple and safe technique. It's done now in America, in Saudi Arabia, in Emirates. I mean, in Italy, in these rich countries also. Why not? And I'm always giving this slide. You can see the one on the left. He's the Turkish guy that has the silver medal in Qatar Olympic Games with a simple procedure, just going and shooting. He did good result. So why would you go through the right one that is a very complicated procedure to have the same result? Thank you very much. So this is my talk. Hope I didn't spend much time doing that.
Thank you very much, sir. It was an amazing talk. I'm trying to turn my camera on. I think it's I've got a little bit of issue in my camera. Okay, okay, okay. There it is. Thank you very much, sir. It was an amazing talk. It was so insightful and so elaborate, sir. Thank you very much. Many people have attended it, and everyone has really liked it. And you have got a very good overview. I also shared your paper so that everyone can go through the paper before, during, or after the session, and they can have some more idea about it. Sir, we do have a couple of questions.
Yeah. Yeah, I've
Uh,
seen them.
yes,
Yes.
sir.
So how we do with 55 years old, we are strict now. It's a process for early onset scoliosis. So it's not a non-fusion, definite non-fusion technique. Still, we are looking how to deal with early onset scoliosis. So I cannot go further for as a non-fusion procedure as a whole. We might work on that in the future. Actually, this is one of the issues that I'm thinking about as plans for the future and more studies about the non-fusion techniques as a whole. But we don't do it even in adolescent idiopathic. We don't go through this technique in even adolescent idiopathic. And also, so when approaching juvenile idiopathic scoliosis, are there any considerations with regard of reoccurrence? Well, the same procedure. For example, if you have juvenile idiopathic scoliosis, actually, it's the best. If you want to begin with the APC, please don't begin with severe, like one of my dear friends tried to begin with a case of neurofibromatosis 90 degrees. I don't advise that. I advise begin with juvenile idiopathic with the same technique, the same issue. And the APC is done for any type of etiology. So it's not contraindicated in congenital or syndromic, but the best results are for the neuromuscular and the idiopathic ones. So in juvenile, 8 years of age, juvenile, 9 years of age, just go with the same technique, nothing else.
Sir, also the growth limitation. Sir, how do you see it as,
Oh
APC?
yeah, oh my God, I forgot to tell you. In the C arm, when you go and see the derotation, you see the stem of the screw. It shouldn't go lateral unless, for example, the curve is so big, I mean, like 100 degrees and it's very stiff. That's fine. But you try to see the stem of the screw is changing, and it has changed. And this is very important as a proof of you have done really derotation.
Thank you very much, sir. Sir, there's also a question regarding the intraoperative neuromonitoring. Would you like to would use this, or in case we do not have intraoperative neuromonitoring, how would you proceed?
Don't do it without neuromonitor. Never. Actually, even when I go to any country for global activity, uh, I insist that we must have any. Now, the neuromonitor is something crucially important in our practice because if it happens once with a paralysis, it's a crisis. And with these early onset scoliosis, you must do MRI for the patient to exclude any intraspinal lesion. But you cannot predict what will happen, especially when you are doing the medial translation, derotation. It hugely correct, as I've shown you with the case of the 80 degrees, it became 30 degrees. So you cannot know exactly when you are overstretching the spinal cord. So don't do it. I mean, in general, for early onset scoliosis, two things to add. It's not a must in adolescent idiopathic, especially if you don't have resources. You must have an MRI for every patient, and you must have a neuromonitor for every patient.
Thank you very much, sir. Also, there are questions regarding reoperation rates. How much do you think as compared to Sheila? How do you think that the reoperation rates are as compared to Sheila?
Well, you can look at my papers. Actually, as I told you, there are 7 papers
Yes.
about the APC, and I compared the complications, and you can see the paper that won the prize that I've shown you. Actually, it talks about comparing the Sheila and the MCGR with the APC. Though, to be also fair, the APC has shorter term follow-up, which might give a false impression about the superiority of it. So we need to go to midterm follow-up to be sure that it has really less complete. But until now, for the short-term follow-up, 5 years, I mean, I have cases of 7 years follow-up. But the thing is that, yeah, in comparison, the complications are less, the crankshafting is less, and also the unplanned surgery is much less. And look at the paper, you'll see the details. By the way, there is another thing, thank you for reminding me with this question about it, is that we did a study. It was published in a congress, so it was not published as a paper in a journal. But I took the cases that we did 27 cases, 13 of them, the APC was the first surgery, the index surgery, and the other cases were secondary to other surgeries. So, for example, patient had a traditional Gromgrad or MCGR or Vipter, and you change it to the APC. We realized that we had, for example, 14 unplanned surgery in these 27 patients. 13 of them were the secondary. So please try to do the APC as an index surgery, because when you do it as a secondary to a previous surgery, the results are not so good.
Exactly. So
And
that
70 from our study, 73% of the complications that we had were from the secondary ones, not the index surgery, the APC index. So please do it as an index surgery, at least in the beginning. Then you can go forward and replace or do something else.
so is there any specific time, the age that you would prefer the APC to be performed?
Well, let me talk in general. For early onset scoliosis, I would try my best not to do it before the age of 3, because the spine is so small and the screws. But in general, as I've said in the beginning of my talk, that I try to delay the surgery as much as possible. For example, if I have a child with congenital scoliosis 60, 70 degrees and it's progressing, I try to put the cast under GA, like Mehta technique, but I tell the family it's a delaying procedure. It's not a definitive procedure. So if I can do it five, it's much better than four. If I can do it surgically six, it's much better than five. But for the upper age, for the surgery, it's so simple. I'm going with the SRS definition. You need to look at the triradiate cartilage. It shouldn't be fused and it should be less than reserve 2 in general. But it's not the age. Actually, in our uh, uh, population of early onset scoliosis, you can see a child 12 or 13 years of age, and it's a part of a syndromic, and they are having huge delay in the growth. So you need to go through the skeletal age more than the age by itself. But in general, of course, you can say below 10, after 10.
Exactly, sir. I think also there is some question I can see regarding the instrumentation, sir. And also, sir, there was some question regarding blood loss since there has been so many steps that people can see, so they are a little concerned about the blood loss.
Yeah, well, this is also another issue when I talk about the three limited incisions that will decrease actually the blood loss for my cases now are 100 cc, that's all.
Mhm.
So, yeah, so you go through three limited incisions as much as possible, but it shouldn't compromise your technique, or you just connect them with an incision. And the other thing is that when you do the surgery, you can realize that we are going just through proximal anchors, just two levels above, two levels below, three levels in between. That's all. And on the concave side, you don't touch anything between the proximal and distal. So you don't distract soft tissue a lot. You don't do that a lot. And also with the Wilson technique, you also decrease the blood loss as much as possible. And also, you must يعني be oriented about these children that I mean 200 cc is a lot for a 10 years for a 10 kg old child, unlike the adolescent idiopathic. So your technique in general must be focused on that. But in APC, since you can have less invasive technique and you go on the main curve with a Wilson technique, you decrease the blood loss a lot.
So there is also a question regarding can we somehow perform it through MIS, the minimal invasive way?
Yeah, well, it's a less invasive technique. Let me say
Yes.
less invasive technique. I wrote a paper as part of the minimal invasive techniques in early onset scoliosis, which is true, but I prefer to be more realistic. It's a less invasive. But if you have a navigator, I mean, you can just put the screws on the tethered area with the navigator without touching anything. Actually, I did some of my cases with percutaneous screw on the convex side in the apex, but it needs a lot of experience and a lot of C-arm imaging, because you want to be sure that you are in the point without even touching, anything. Just a small incision on the skin, and you just put the screws and you go with the rod. By the way, if you want to do it less invasive or minimal invasive, you go with the rod under, try to put it subfacial or under the muscle. Don't do it under the skin. And also with the domino must be put in an area that can be covered by soft tissue because these children are having very tiny, I mean, body. So you don't need to have the domino bulging like under the skin. And also, don't ever put the domino proximal near the proximal anchors because with these children they are having very small soft bones and you are putting screw and the domino might be a stress riser that will dislodge the rod up. So you try to put it in in the thoracolumbar area that you can. And this is one also of the advantages of the APC. Since you are using regular rods and the domino, you can control it where to put it. I mean. And also another thing, when you put the sliding rod, it must be straight. Don't ever, adjust it in a way or another. Must be straight so as to have the gliding. And also, we realized from our experience in the beginning, I was putting the domino. For example, if you want to put a 5.5 rod, you have a domino with a hole 6 or 6.5. And this resulted sometimes that the soft tissue will be, will go inside and will stop the gliding of the rod. So we realized that if we put the rod, for example, 5.5, in a hole 5.5, it will glide very well. And there is no chance that a soft tissue will just prevent or lock in a way the rod from gliding. These are two major issues also in the practice when you do it.
And so, do you use? Would you like to use hooks in your ACC?
Yes, in the kyphosis. Actually, when you have a kyphosis, the proximal anchors, because you are doing, okay, this is the scoliosis, but if you go with the kyphosis, this is the posterior part, this is the anterior part. So you go and try with the same principle, trying the cantilever effect and compress the convex side, which will distract the concave side anteriorly. So when you do the cantilever effect in a children, like, very small children, most probably you'll dislodge the screws, the proximal ones. So I put hooks, either putting hooks on the ribs or sublaminar hooks on a clawing fashion. The proximal hook will face downwards, the distal hook will face upwards, so it will be a clawing fashion, and you can use it in the yeah. I use it actually in the kyphosis. And by the way, if you do a strict kyphotic case, I usually don't put domino in the index surgery because for example, in the kyphosis, when you do the correction as we said, and you open it, the domino will decrease this performance. And also the rod from the domino will come and will impinge under the skin because you are in a kyphotic area. So I put the rods as just like a traditional growing rod, but put screws above and below the most wedge vertebra, compress medial, anterior, translate, let me say here, and wait until the spine will adjust with some instance, and you cut the rods distally and you put longer rods and then you put the dominoes.
That's amazing, sir. Sir, we are taking a lot of your time, but it's a very interesting talk, and there are so many questions that are being considered there. Sir, is there any specific complication in the long term or in the short term you will be looking after specifically when you operate the patient?
Yeah, like any complications in the early onset, either instrumental complication like
Yes.
dislodging of the screws or fracture of the rods. Actually, I did also in my practice. I thought that 4.75 cobalt chrome equals, mechanically speaking, 5.5 titanium. And I used 4.75 cobalt chrome, but in a 9 years heavy built old child, and that was wrong because I had two cases with broken rods. So I put the 4.75 cobalt chrome in very young age, like 4 years, 5 years, 3 years. Otherwise, I put the 5.5. So you can have complication. The other complication is that you didn't control the apex, and this is one of the issues that I'm planning to learn more about it. Where is the red line for the APC? For example, I was doing that, and I was saying previously years ago that don't do it above the cup angle of 80, but I do it now for 100. Whether you can control the curve appropriately or not, how much compression do you need? These are questions that we need to answer in the future, and we are now in the process of doing virtual computational studies that will teach us more and more to get the APC more effective and more efficient for our children. But of course, we have a lot of issues to understand more and to search, and we need midterm results at least to know where we are going exactly with this technique. But the thing that APC have done is the concept of posterior tethering in a way that you can control the apex of the curve.
From computational surgery, I can actually remember that there are so many several softwares that have the potential to train or to potential to learn regarding the planning of surgery, including, this is very simple app that actually calculates the Cobb's angle. If you have the image, you just put it in and it calculates the Cobb's angle and everything, and it gives you a little bit of insight. So, do you
Yeah.
think that the application of AI can help?
That,
that
do
that
you think
application
that?
of AI can be helpful in planning of surgeries, of complex surgeries.
Well, the surgery is simple, actually, but we need to have the AI can help us in gathering data of multi-centered. And I'm so lucky that though I invented it, I mean, with a short, I mean, very near relatively to the other techniques, but because it is disseminated globally, we have more than 150 cases, which is something that I'm lucky to have. So what is AI? AI is artificial intelligence that you can gather the data with long-term follow-up that will give you that this patient is not a real good candidate for the APC, and this patient might be good candidate for the APC. So we are trying to have that absolutely. The AI should go through this way, and we are planning in the near future to put that in the way. And also, even the disc, as I told you, we studied the modulation of the vertebra by itself. We are studying now the disc. We are doing now a multi-center study about the health of the disc, whether it will affect and how it will affect and these things. Yeah.
So is there any, so this is the last question, but is there any specific post-operative advice or rehab that you would be emphasizing on in your patient after operation?
In general, I don't put a cast or anything after surgery. In general, I just get the child to walk, to stand, to walk on the first post-operative day. And they can do whatever they want except for lifting heavy weight and doing sport for 6 months. I mean, like the adolescent cases, unless you are having children that you are worried about your fixations and the bony quality, and if it's so, osteoporotic, and you are afraid of this, everything would dislodge. You might put the cast for 6 months or something like that. I did it once or twice, but it's not, routinely done.
That's incredible, sir. So, sir, thank you very, very much, sir. It was an insightful and amazing and a very interesting talk. I think everyone has learned so much from this talk. I have the recording, which will be available shortly on my YouTube channel and also on neurosurgical.tv. I've got a collaboration with John Bennett for this. So it's going to be online or everywhere on the internet soon. And thank you very much, sir, for the discussion. I think we took a lot of your time today for discussion, but it was very interesting and insightful. And I think that this will be incredibly helpful for all the viewers and everyone who is interested in this surgery. Sir, I've received a lot of compliments for your talk. Dr. Islam has also sent you. Thank you very much. There are a few people who have sent me text on WhatsApp and they have really appreciated the talk. And thank you so much, Professor, for this wonderful lecture. I know this month we observe scoliosis. It is important to educate and create awareness. So thank you very much. We owe a lot to teachers like you, and I think that
Thank
the
you.
field is thriving because of you, sir. I think we were all lost if we were not being found by teachers like you, because it means a lot.
Oh, I'm honored. I'm honored to participate, and thank you for having me and giving me the chance to talk about the APC in a more clarified way. And hopefully, again,
And
we should be having a sense of science, more multi-center studies, more data, more long-term follow-up, and more honesty in looking at the data and trying to learn more. And this is the beauty of actually going, at least for me, talking about my going through the APC, is it gave me the chance to open my mind to more and more understand how the spine grows and how can we deal with it. And still there are millions of questions that we need to answer. And this is the beauty of science.
Science is as an ever evolving field, sir. And obviously, there is nothing which is final. Everything is relative in science, and it is like always a
Yeah,
thinker. Exactly. So it's like ever evolving thing. So we cannot be fixed at one point. So this is incredible, sir. But you have like you have elaborated it in a very good manner, and there is also a logic which is there, which is incredible, and the application, because there is whenever we are talking about any technique, we first think about whether I can do it in my setting, whether it's possible to do in my setup.
yeah,
So this is something that we have like already discussed, and whether what we are doing, is it, are we going to cause more damage, more harm, or they are going to be benefit? And these are some of the questions that we always ask whenever we are selecting any technique. So this is huge. So thank you very, very much, sir. So Dr. Faiz
thank
Obed
you.
has Dr. Faiz Obed has sent you special thanks. And also Dr. Ahmad Fawad Pirzad is the president of the Afghanistan Society of Neurological Surgeons. He's also sent you special thanks for the excellent webinar, Dr. Pirzad from Afghanistan Society. Sir, many
Thank
wishes
you.
from Pakistan to you, and
Thank you
thank you
very
very
much.
much. I'm currently right now in my home country in Pakistan. So many wishes, and sir, it was an honor, and I really wish, it's my great wish that it will be. I will think it will be a good privilege to invite you again for another talk.
I'll be honored. I'm honored always to be with you. Thank you
Honor
very
it will
much.
be. Thank you very much, sir. Thank you very much, sir. And I hope that everyone had a wonderful time. Thanks a lot, sir. See you again, sir. I
Thank
think
you.
it's time to wrap up
Yeah,
the session.
thank you.
Have a wonderful day, everyone, wherever you are. Thank you very much. So, everyone,
Thank you.
bye. And
Bye.
have a wonderful day, sir. Thank you so much again.
Thank you very much. Bye.